Hello, I'm Dr. Simon Johnson and I work closely with TSC patients with LAM, and now I would like to share my experiences with you. Because the vast majority of patients who present with TSC-related LAM are women, the Tuberous Sclerosis Alliance guidelines recommend that women with TSC get screened for LAM at or after the age of 18. So usually, LAM is identified through screening. High-resolution CT is one modality to use for screening. CT gives nice detail of the lung fields, and I think that it's certainly important to know if a patient has LAM, particularly a woman who may be exposed to estrogen through treatment or who may be considering pregnancy, because these are important factors in the disease. For patients who are not routinely screened, LAM is usually detected when patients become symptomatic. However, other TSC patients might present with LAM through incidental findings. Renal angiomyolipomas, or AMLs, non-cancerous tumours of the kidney, often co-occur with LAM, so when patients have symptomatic renal angiomyolipoma, LAM is also suspected. In my clinical experience, patients may go to the hospital and have a CT scan for a kidney tumour, and doctors catch sight of the lungs just at the bottom of the CT image, so LAM might be identified that way as well. The hallmark of LAM is lung cysts, which are visible on CT scans. Lung cysts are air-filled spaces in the lung parenchyma. Their size varies, but they typically range from 2 to 10 millimeters in diameter, but occasionally they can be as large as 50 millimeters. They tend to have thin walls that show up on CT, and they tend to be distributed fairly evenly throughout the lung field. So from front to back, top to bottom, you tend to see the cysts. And typically, what I've seen in my own clinical experience is that the more cysts there are, the more severe the disease is. But sometimes there's only a very small number. Additionally, in patients with TSC, you'll see small nodules on the CT coexisting with LAM, or sometimes without LAM. These are called multifocal micronodular pneumocyte hyperplasia. They're not part of LAM, but they are often seen in conjunction with LAM in patients with TSC. In my opinion, making a diagnosis of LAM in patients with TSC is easier than making a diagnosis in patients with sporadic disease. So if you see a characteristic lung CT, which means lung cysts with thin walls, evenly shaped, distributed evenly throughout the lung fields with normal intervening lung parenchyma, all within the context of definite TSC, I personally feel there is enough evidence to diagnose LAM without performing further tests such as a lung biopsy. The main biomarker that has been described that appears to be clinically useful in detecting and diagnosing LAM is vascular endothelial growth factor type D, or VEGF-D. Recent findings have shown that patients with LAM have higher circulating VEGF-D levels than patients with other lung diseases. And in the context of TSC, a raised VEGF-D level is associated with the presence of LAM. When you look in detail, what you also see is that an elevated VEGF-D level is strongly associated with the presence of cystic lesions in the lymphatic channels. So we find that to be a useful biomarker now.